This time I'd like to call the Joint Committee on Health and Human Resources to order. The chair will look to the clerk to take a silent roll. I'm so informed we do not have a quorum, so we'll have to pass on the minutes. Next, I will call upon our first presenter, Cindy Dillinger, who's the Chief Counsel for the Senate Health and Human Resources Committee. The podium is yours.
Thank you, Mr. Chair. I wanted to be here today just to give a brief explanation. We previously asked Disability Rights West Virginia to present to the committee today. They were unable to present today. They were going to discuss their concerns regarding abuse and neglect at Sharp Hospital. We hope to have them present to the committee in December, and we will keep you informed as to the status of that invitation to present before the committee. And that is all I have. We just wanted to provide you with that update.
Okay, then obviously there'll be no questions. Next, I'd like to call to the podium Dr. Angela Cherry, who's a member of the West Virginia Perinatal Partnership Advisory Council. Doctor, would you please come forward? As is the custom of this committee, we will swear you in. Raise your right hand. Do you swear or affirm that the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
The podium is yours. Please state your name and position for the record, and we look forward to your presentation.
Good afternoon. My name is Angela Cherry. I am the program director for the West Virginia University Rural Family Medicine Program and also advisory council for West Virginia Perinatal Partnership. So what I'm going to speak to you briefly about today is improving maternal and infant health outcomes through partnership. So West Virginia Perinatal Partnership is a statewide quality collaborative of healthcare professionals and public and private organizations committed to improving health outcomes for pregnant women and their babies. You see, our mission is healthy mothers and healthy babies in a supportive community. Our mission is to engage and unite healthcare providers and stakeholders in improving maternal and infant health outcomes. The West Virginia Perinatal Partnership was founded in 2006. The Perinatal Partnership works through a variety of committees to develop new programs, improve existing programs and policies, and implement best practice standards of care to create the best care possible for pregnant mothers and our babies. So you can see here the strategic priority areas. So driving our work, you can see here, oops, I apologize. Driving our work here, you can see there's four main strategic priority areas that we have. I apologize here. Excuse me one second. I'm sorry, this is not. But the four strategic priority areas. So number one, we have a perinatal system of care with our West Virginia mothers. Sorry. So I apologize. So perinatal system of care for our West Virginia mothers and infants will have equal access to quality care system no matter where their location is. Number two, we want improved health outcomes of West Virginia mothers and infants through early identification and prevention, quality treatment, best practices and standards of care, and responsive policy changes. Interdisciplinary education and outreach to ensure optimal educational opportunity levels are available to providers statewide. And awareness and advocacy, so we can build awareness and support of the partnership and its policy priorities. All of these align to show here our key priority areas. So maternal and infant mortality and morbidity are impacted by these key priority areas. And this is why we focus on these areas. So 10 major issues that affect birth outcomes in West Virginia. And these are the key issues that were derived from a key informant survey in 2013. So funding for this work comes from grants from the Office of Maternal and Child Family Health, HRSA, HEPC, and other project-specific grants, such as Our Moms grant working on improving access to care in pilot counties. So first, we're going to talk about the demographic overview of births in West Virginia. So you can see here between 2010 and 2020 census, the West Virginia population of birth trends here has decreased, just as it has decreased over time in the US. So birth trends are going down. But interesting, in West Virginia, the population itself has decreased by 3.2% over the same time period. West Virginia now has 20% of the population over the age of 65. So it's one of the highest rates in the nation. So as expected, we would expect that these birth trends to be going down, but you can see consistently they have gone down over the years. This year, in 2020, between 2020 and 2001, the actual birth rate in the US increased by 1%. That is first that has happened in 7 years, and we have not seen that increase here in West Virginia. Interesting enough, West Virginia actually has more deaths than we have births, and we are one of 4 states that has that happening at this time. The other 3 states are Maine, New Hampshire, and Vermont, which is a little bit interesting because that's not the usual states we're paired with. This here shows all home births. This is not just limited to West Virginia residents, but residents that may be over the borders that have come into the state. So as you can see, there's been a major increase in home births in 2021. Not sure if this is because of COVID and because of what was happening in the world at that point. A lot of fears of women going to hospitals for delivery, of picking up an illness. There was a lot of heightened rules and regulations with the hospital visitor policy, support policies. Not sure if this is something that contributed to this increase, or if this is something that's going to continue to increase. And so this is something that we will have to continue to trend. Nationally, this has also happened as well. So overall, the US had an increase of home births of 22%. And also South Dakota had an increase of 68%, and that was the highest state in the US. So here's a map of our current birthing facilities. Of note, I want to take a look at the hospital in red there at St. Mary's Hospital. So in 4 days, St. Mary's is actually going to be closing. So we will then lose another birthing center in the state of West Virginia. That will bring it down to 20 birthing hospitals with one freestanding birthing center. With the closing of these hospitals, you can then see we end up with obstetrical deserts in West Virginia, and our women are having to travel really far to get to these hospitals that are doing these deliveries. Here you can see the West Virginia births by pay source. It's pretty equal. In 2020, only 1 of 10 women of childbearing age was uninsured in West Virginia. You can see here's the West Virginia births by race and ethnicity. We're going to go talk a little bit about the birth outcomes. So here you can see where we fall with compared to the rest of the United States. With cesarean deliveries, we're the 7th highest in West Virginia. Preterm births, the 4th highest. Low birth weight, the 10th highest. Very low birth weight, the 14th highest. Teen birth rate of 8th highest. Infant mortality, 8th highest. And maternal mortality, the 20th highest. And so we're going to talk a little bit more about low birth weight infants and very low birth weight infants as I go on. So you can see here, birth data according to the mother's race and ethnicity. And so what I find interesting about this is you can see as we talk about in medicine, a lot of the racial disparities that are happening, you can see they are happening in West Virginia as well, with our minorities having increased rates of low birth weight infants and also preterm deliveries. So now maternal and neonatal morbidity and mortality. This is a little bit older map, but it shows you where we're at compared to the rest of the states. So here in 2015, you can see where we are according to with maternal mortality. The maternal mortality is defined as anything that causes death within 42 days of pregnancy, okay, the termination of that pregnancy. So you can kind of see this, of course, isn't from 2015, it would need to be updated. What we are seeing now, though, unfortunately, we are having an increase of our maternal deaths secondary to accidental drug overdoses, which I'm sure everyone knows. You can see that that's 42%. Childbirth, 15%. Suicide, 6.8%. Other accidents include MVAs or drowning, motor vehicle accidents or drowning. Other natural causes causes from natural causes, including diabetes, heart disease, stroke. So natural medical causes will cause the other natural causes of those deaths. But the most important thing about this is that this is all preventable. So these are the things that the partnership looks at to try to prevent. A majority of those deaths really are preventable. So how do we address maternal mortality? And what is the partnership doing? So this is the AIM bundles, as some of you may hear sometimes. It's the Alliance for Innovation in Maternal Health. And nationally, these bundles have been created based on data that really addresses these issues that we have with maternal mortality and morbidity. And so with that, the West Virginia Perinatal Partnership has really led the implementation of these patient safety bundles in West Virginia with technical support from national organizations, including the American College of Obstetricians and Gynecologists. The partnership works with every hospital, so every delivery hospital in the state, to address their readiness and response to obstetrical complications. The partnership has taken on the first two safety bundles, which is hypertension and postpartum hemorrhage. This slide looks more at maternal morbidity. And so morbidity is defined as any complication that may contribute to mortality. So this is all women who have delivered in West Virginia and those who experience some severe OB complication that contributes to this morbidity. Here we are again compared to the rest of the United States. And so you can see this is data from 2019, but this also gives you an idea of where we fall within the rest of the states. Here we can see the infant mortality rates. We're going to talk a little bit about that according to for West Virginia compared to the rest of the United States. You can see this data is established by the West Virginia Perinatal Partnership. And so you can see that as infant mortality is decreasing, we still are concerned because our moms in West Virginia still do have a little bit of a bump and an increase in infant mortality compared to the rest of the United States. This also, you can see, this is the relationship with infant mortality, with smoking, and also other drug use. Looking at more of the infant deaths do happen with moms who smoke or do use drugs that are illicit drugs, which are non-prescribed or illicit drugs when we talk about drug use. And so there is an association between the smoking and also the drug use, which does contribute to our infant mortality. Here you can see a little bit of those trends as well, which what I talked about earlier as far as racial disparities. The top line there is Black non-Hispanic. So even here in West Virginia, there's a higher infant mortality rate compared not only to all races, but significantly higher. Here we'll look a little bit at prematurity. So prematurity is less than 36 weeks and how maternal smoking affects that. So you can see, again, our smoking rates are so much higher that it does contribute to higher rates of prematurity as well. So here's a little look at the state and a little bit a map as far as our counties to look at which counties are experiencing the highest rates of maternal smoking. And also, I'm sorry, the prematurity rates, which ones are experiencing the highest rates of prematurity. This next slide looks at the smoking. And so you can see it's very similar when we're looking at those two maps of the state. Our goal, you see West Virginia here is 22.3, but our goal really is to be 12.2. So we have a little ways to go with this. So that's where our initiatives of the West Virginia Perinatal Partnership come into play. So first, some of the current initiatives that are occurring. First, analysis of our birth outcomes to hospitals' levels of care. So making sure that they are at the appropriate level of care and treating the patients that they should. The next is the project is to reduce the incidence of very low birth weight infants born outside of tertiary care centers. And then finally, help to quit nicotine cessation project, again, because of the high risk of smoking and preterm births association. That is something that we are trying to work on. So low birth weight infants, here are the You can see the slide of the counties in West Virginia as well. So low birth weight infants are less than 2,500 grams, and less than 2,500 grams is 5 pounds and 3 ounces. So if you think about a 5-pound sack of potatoes, that's the weight of these babies that we're talking about. When we go to very low weight babies, or you're looking at even smaller than that, and you're looking at maybe a small bag of apples, which may weigh 3 pounds and 5 ounces. These are the babies that we're taking care of. And so 1 pound, just to give you reference, is a bag of coffee, and a gallon of milk is 8 pounds. So smaller than, as far as weight, we're talking about smaller than 8 pounds. These are the babies that we're taking care of and that we are serving here in our state. So Project Watch is the West Virginia birth score. So what the birth score does, it works to identify high-risk infants and critical congenital heart disease and hearing loss in West Virginia. So this chart shows you the percentage of infants with some type of substance exposure in utero. Also, this chart shows the percentage of infants diagnosed as experiencing neonatal abstinence syndrome. As you can see, there has been a decrease. There has been a lot of work to try to decrease the effect that these drugs have on our babies to try to get moms into treatment programs, as well as to identify these things, identify drug use early in pregnancy. So Drug-Free Moms and Babies is a program from the West Virginia Partnership that addresses those issues. And you can see here, this is currently where those sites are located. And what Drug-Free Moms and Babies, it's a program that deals with care coordination. And so as I spoke earlier about also giving prenatal care, labor and delivery units, postpartum care, so routine OB care. But in addition to that, let's add the care coordination for all the other services that moms may need. So they need outreach. Also for communities to do a needs assessment to see what they actually do need in their communities. Follow-up, referrals, and helping moms get the appropriate care that they need. Also home visitation, WIC support, housing, childcare, transportation, all of those things that moms may need. In addition to, if there is a substance abuse disorder, making sure that they are on medication for opioid use disorder, and individual and group counseling. So all that program brings all of those things together to help serve our moms better. Any questions?
Do we have any questions of our presenter? Delegate Tully.
Thank you, Mr. Chairman. Thank you, Dr. Cherry, for being here. I have a question about slide 36. And what this slide pertains to is the percentage of very low birth weight infants born at non-tertiary care facilities. And I noticed there was a pretty dramatic increase in 2020. Do you have any reasons for that? Is it because of bed availability at the tertiary care centers because of the pandemic, or any prognostication of why that occurred?
I would suspect, not for sure, but I would suspect that that is the cause, because as we've gone through the pandemic and as we're going through now, a lot of our bed availability at the tertiary centers are limited. And so we know that once a mom delivers outside of a tertiary care center, they have worse outcomes. And so our goal is really to get them to those centers. But if the beds are limited, then it is difficult for us to do that.
I would be curious to see, do you have any information on the occupancy rate of those beds at the tertiary care centers that you could provide to the committee?
I do not. Each hospital would have to provide that. I do know that some of those issues have to do with staffing. And so I always say that when you're looking at bed occupancy in all these hospitals, you really need to know what beds are available and which beds are able to be staffed. And so I know that we address that, at my hospital all the time, but for all the tertiary centers, you would have to ask the individual hospital. I'm not sure. I have Melanie Riley here with me. She's part of the West Virginia Perinatal Partnership as well. I'm not sure if the partnership has true data on that.
I would love to see that data come forth. And if it comes from the hospital association or who it has to come, I think that's important information. And you're exactly correct, because just because you have a bed doesn't necessarily mean it's a staff bed with appropriate personnel. Thank you so much. I appreciate your time.
Sure.
Any other questions of our presenter? Delegate Reed.
Thank you, Mr. Chairman. Thank you for being here, Dr. Cherry. I got a question on your slide 21. you have listed homicide as 9%. What was the total? And on the slide before that, you had data from 2007 to 2017 with a total number of deaths, 26. And then you have 217 to 221. What was the total number of deaths for that amount? And where exactly was these homicides occurring in West Virginia?
I'm not sure exactly I'm not sure the specific place for those homicides because that is tracked by another group. The slide I realized here, I might not be seeing it, but there has been an increase in deaths over the past 10 years. I'm not sure if that slide was there. I'm not seeing it here. But those actual deaths, even though it is a smaller number, but they are increasing, which is a problem. But as far as where those homicides are occurring, I don't have that information right now.
All right, thank you so much.
Delegate Zukov.
Can you hear me now? Okay. Thank you for being here today. I had a question on slide 37. Okay. The substance exposure slide. Do you have this information by county?
Melanie, yes, we do have the information by county. Melanie might be able to discuss that a little bit further. This is data that's collected from all counties.
Okay.
So it is by each county as well. It's just, I don't have it here on this slide.
If you could share that with the committee, that would be wonderful. Thank you.
Sure.
Any other questions? None being seen, we thank you for your presentation and we'll call our next presenter to the podium.
Thank you.
Next, we have Matt Izzo from the Office of the Chief Medical Examiner concerning fatality mortality review teams.
Yep. Enter.
Mr. Izzo, as is customary, we do swear you in. Do you swear or affirm that the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please state your name and position for the record, and we look forward to your presentation.
Thank you, sir. My name is Matt Izzo. I'm the Chief Administrator for the Office of the Chief Medical Examiner. Good afternoon, distinguished committee members. Thank you for the opportunity to make this presentation today. I'm present to provide a brief overview of the West Virginia Fatality and Mortality Review Team and work being conducted by the 4 review panels that the FMRT provides oversight and direction for. Speaking to you today on behalf of Dr. Alan Mock, the Chief Medical Examiner and Chairperson of the FMRT, Dr. Ayn Amjad, the Commissioner of the Bureau for Public Health and our State Health Officer, who's a member of the FMRT, Colonel Jan Cahill, the Superintendent of the West Virginia State Police and FMRT member, and Mr. Chuck Miller, the Prosecuting Attorney of Kanawha County and the 4th FMRT member. As you're likely aware, the legislature created the current Fatality and Mortality Review Team in West Virginia Code Chapter 61, Article 12A in 2013. The FMRT is a multidisciplinary team created to provide oversight and coordination for the examination, review, and assessment of deaths which fall under certain categories that are outlined in detail within the aforementioned code. There are currently 4 review panels, also described as advisory panels, that the current code established. The Unintentional Pharmaceutical Drug Overdose Review Panel, also known as UPDORP, the Infant and Maternal Mortality Review Panel, also known as IMMRP, the Domestic Violence Fatality Review Panel, also known as DVFRP, and the Child Fatality Review Panel, also known as CFRP. For administrative purposes, the Fatality and Mortality Review Team is housed within the OCME and its daily work is managed by our OCME Fatality and Mortality Review Program section of our office. The OCME provides coordination for 3 of the 4 review panels, child, domestic violence, and UPDORP, while the daily work and administration of the IMMRP is housed within the Bureau for Public Health Office of Maternal, Child, and Family Health, OMCFH, and that office provides coordination for the panel's work. The code established a requirement for each panel to submit a report annually to the FMRT and for the FMRT to provide a consolidated report to the governor and LACRA by December 1st of each year. Until now, the FMRT has failed to properly meet this requirement. Specifically, the panel reports that were previously completed by the Child Fatality, Domestic Violence, and IMMRP were not consolidated and submitted as an annual report to meet the code mandated requirement. It was discovered that some of the individual panel reports completed by the Child Fatality, Domestic Violence, and IMMRP were improperly submitted as individual reports, some of which were published on the West Virginia State Agency report section of the West Virginia Legislature's website. The UPDORP was not constituted prior to 2022. Therefore, the 2022 report contains the first submission for UPDORP. Since notification of this deficiency, the DHHR, BPH, OCME, and the FMRT have taken the appropriate steps to create consolidated reports that include each of the legacy reports that were not properly submitted previously in order to ensure that the submission requirement is up to date before the December 1st deadline in 2022. The FMRT is aware of the prior failure to meet requirements, and proper processes and procedures have been implemented to ensure that the reporting requirement is consistently met in the future. The work conducted by each of the review panels is predicated upon conducting reviews of closed cases. To determine if a case is closed, there are 2 simplified questions that can be applied. First, has cause and manner of death been finalized? And second, are there any associated criminal legal proceedings still in process? To determine if cause and manner has been finalized, there are 2 indicators to review. First, has an autopsy report for an autopsy case or a death investigation report for a non-autopsy case been published? And second, has a death certificate been finalized and registered with the state registrar for the particular death? Determination of the status of any criminal proceedings in process can be answered through either the issuance of a verdict by the court or the failure to prosecute by the prosecutor with the appropriate jurisdiction. The review panels only review closed cases for 2 basic reasons. Number 1, death investigations have innumerable variables that change throughout the course of a medical legal death investigation, which makes the issuance of preliminary reports a speculative endeavor that does not properly serve any stakeholder. Number 2, if a case is part of a criminal prosecution, all parties have a responsibility to ensure that any process involving that case does not hinder or impact a prosecution or defense in any way. All deaths are reviewed to determine if they are subject to a review by any of the panels. In the most basic terms, this can be accomplished by applying the screening criteria developed for each of the panels. For example, if a death involves a child and that death may have been preventable, it may be appropriate for a child fatality review. If the death involves an infant, is pregnancy related, or meets the definition of a maternal death, it may be appropriate for the IMMRP to review. If the death is a result of an unintentional pharmaceutical drug overdose, it may be appropriate for the UPDORP. And if a death has a domestic violence component, it may be appropriate for the domestic violence review. Cases subject to review by the panels are prepared for review at different points in time and are subject to being closed as discussed previously. Each of the review panels has different timelines, caseloads, investigative approaches, and processes that comprise the panel work. As such, the panels are currently working on different schedules and calendar year reviews. It's important to note that COVID-19 pandemic has had a negative impact upon case closure timelines, as has the backlog related to autopsy case closure at the OCME. Currently, the child fatality panel is reviewing deaths that occurred in calendar year 2019. Domestic violence is 1 year behind that and is reviewing deaths that occurred in calendar year 2018. The UPDORP just recently completed a 2022 report and will be reviewing the second half of calendar year 2021, which is July through December. And the IMMRP is currently reviewing infant deaths from calendar year 2018 and maternal deaths from calendar year 2020. The 2022 FMRT annual report will include the most recent reports compiled by each of the panels. As you can see, there have been significant number of cases for each of the panels to review over the last several years. The reports contain data generated regarding 324 cases reviewed by child fatality, 342 cases reviewed by domestic violence, 798 cases reviewed by the IMMRP, and a report covering 2,910 deaths studied by the UPDORP. In addition to the formal review panel meetings, which occur monthly or quarterly in accordance with the outline displayed here, there is daily work conducted for the panels by staff at the OCME, OMCFH, Health Statistics Center, Board of Pharmacy, and other entities. There's a large amount of triage, review, collection, and preparation of records required in advance of these formal meetings. The multidisciplinary nature of the panels and the fact that panel members serve in a secondary capacity to their primary employment responsibilities requires that the administrative burden of conducting case reviews be assumed by employees and contractors of the various state entities who are stakeholders in the review process. Due to the small amount of time available in this venue, it's not possible to review well over 125 pages of data, findings, and panel recommendations contained within the annual report. As a synopsis, Dr. Didden and myself shall present a snapshot of some of the data from the review panels. Pardon me. In the child fatality review section of the annual reports, readers will find the data generated from the review of child fatalities which occurred in calendar years 2015, 2016, 2017, and 2018. The 324 deaths reviewed during the 4-year span covered by the reports have generated some measurable statistics in several demographic areas across 5 different manner of death classifications that are available on West Virginia death certificates and across various cause of death determinations associated with child deaths reviewed during the time frame. Each year of review also contains recommendations developed by the panel members for decreasing the number of child deaths in West Virginia. The graph depicted here shows that during the 4-year period, 41.6% of deaths reviewed were determined to have an accidental manner, 9.3% to be homicide, 9.3% suicide with an equal number in each of those categories, 1.9% determined to be natural, and 37.9% were given an undetermined manner of death. It's important to define an undetermined manner of death. When a manner is classified as undetermined by a medical examiner, who's the only physician type in West Virginia authorized to certify a manner other than natural, it means that there was insufficient information available for the forensic pathologist to definitively distinguish between 2 or more competing manner of death possibilities. Due to the nature of a medical legal death investigation involving a child, it's not unusual for a significant number of investigations to result in an undetermined manner of death. It's also important to remember that manner of death and cause of death are 2 completely independent categories that are based upon different investigatory components. There's a great deal more information regarding the child deaths contained within the report. In the domestic violence section of the annual reports, readers will find the data generated from the review of domestic violence related fatalities occurred in calendar years 2015, 2016, and 2017. The 342 deaths reviewed during the 3-year span covered by these reports also generated a large and variable number of statistics across many demographic areas and numerous categories. Like child fatality, I chose to display a graph for the domestic violence that depicts the distribution of manner of death determinations in the domestic violence related deaths reviewed in the 3-year period. As expected in this category of review, a majority of the cases were determined to be suicide or homicide deaths. Suicide deaths represent 59.6% of the cases reviewed. Homicides were 32.7%. Accidental deaths were 1.7%. Natural deaths 1.2%. And deaths with an undetermined manner were 4.8%. The same definition and explanation regarding an undetermined manner as discussed with a child fatality applies to domestic violence cases as well. Note that the number of deaths with an undetermined manner in domestic violence cases is significantly lower than the number of undetermined manner cases in the child fatality review section. One of the most significant public health epidemics in all of our lifetimes is occurring right now in West Virginia. No matter what perspective or viewpoint that is used to assess substance use disorder or what label is utilized to describe it, we are losing more West Virginians to overdose deaths than any other non-natural cause of death. The graph shown here depicts a 21-year time span where overdose deaths have increased by more than 615%. The trend line displayed shows a steady increase overall, with some minor decreases in 2009, 2012, 2018, and 2019. But the increases that have followed these short periods of decline, especially in recent years, has been significant. There are many entities, experts, organizations, and stakeholders across the state who continuously track these trends and initiate ideas and programs in response to the epidemic. The 2022 report will include the results of a study of overdose deaths from 2019 through June of 2021. The approach taken by the UPDORP utilizes existing data resources from the Board of Pharmacy, OCME, OMCFH, and the Health Statistics Center. Analysis of overdose deaths that provides an integrated approach and connection of data sets that have unique and independent elements that, when combined, can help to identify trends, patterns, and risk factors associated with overdose deaths is the most effective course of action in reviewing such a large number of cases, as opposed to the more traditional review conducted by the other review panels. We take a different look at overdose death data trends, shifting from raw numbers to specific drugs. We can see how patterns have shifted over time and how the most prevalent substances have changed. Combining data sets allows for a closer study of which pharmaceutical drugs are impacting the overdose death rates and some of the patterns and trends associated across the data sets can be leveraged to inform prevention and treatment efforts. It is with this course of action in mind that the UPDORP has leveraged this work as a basis for 2022 UPDORP report submission. This graphic displays overdose death data from 2019, 2020, and the first half of 2021 across multiple variables with a focus upon substances contributing to overdose deaths in West Virginia during that time period. The y-axis data points include the 7 different substances that comprise the top 5 drugs that contributed to overdose deaths in 2019 through the first half of 2021. It's not surprising that fentanyl and fentanyl metabolites were both the most common drug and second most common drug in a 2.5-year period. The third through fifth most common drugs included amphetamine, methamphetamine, heroin, morphine, norfentanyl, and fentanyl. With these 6 drugs moving between the third through the fifth spots across the 2.5-year period. Through the combination of data sets approach, the report also contains information regarding emergency department visits, prior reported overdose for the decedents, and other variables that will provide data that is useful for prevention and intervention stakeholders. An additional variable that's important in understanding the pathway or supply chain of the drugs causing overdoses in West Virginia is a review of the prescription status of drugs found to have contributed to an overdose death. For example, the data depicted here indicates that in 2019, 53.5% of decedents did not have a prescription for one or more of the substances that contributed to their death. 25% had a prescription, and 14.9% did not have any data on file in the CSMP program. These and many other data points are more fully described within the 2022 report. At this time, I'd like to turn over the presentation to Dr. David Didden, who will use the remaining time to outline the multi-year detailed analysis of maternal and infant mortality and the data included in the IMMRP sections of the report.
Good afternoon, everyone. Mr. Chair, would you like to have me go ahead and?
Yes.
Please swear.
We do have to swear you in. Do you swear that the testimony you're about to give is the truth, the whole truth, and nothing but the truth? So help you God.
I do.
State your name and position for the record, and the podium is yours.
My name is Dr. David Didden. I am Physician Director for the West Virginia Office of Maternal, Child, and Family Health within the Bureau for Public Health. And I also serve as the Medical Director of Overdose Prevention and Innovation Projects in the same office. So I'm a retired family doc. I served as a local health officer right down the road in Jefferson County for 6 or 7 years. And then just a few years ago, made the transition to full-time work in public health with the state health department. So I'll be very brief. I have just a couple slides. It actually turns out they're a bit redundant following the excellent presentation from Dr. Cherry and the West Virginia Perinatal Partnership, but I will show a couple graphs on our infant maternal mortality review panel from the years shown. In this slide, we're looking at 6 years of data from maternal mortality cases reviewed, so just maternal cases. And we see total maternal deaths from any cause, not just those directly related to pregnancy. So these technically are considered pregnancy-associated deaths, according to the definition of the American College of Obstetrics and Gynecologists and the CDC. So from 2014 through 2019, you can see the total number of deaths in the far right category, which does indicate a steady increase over that time period. It is a challenge to compare our rates of maternal deaths to other states because of state-by-state variation in case definitions, as well as the low number of deaths, which makes us a little less confident in our calculation of rates. But I will refer you back to Dr. Cherry's presentation for some excellent epidemiology on those mortality rates. Nationally, there has been an overall trend towards higher pregnancy-related mortality, and West Virginia historically has ranked fairly high, is doing well with those pregnancy-related deaths. For example, from 2014 to 2019, the West Virginia pregnancy-related mortality rate was 14 deaths per 100,000 live births, while in 2019, the estimated U.S. pregnancy-related mortality rate was 20.1 maternal deaths per 100,000 live births. You can see here that most of the cases illustrated were by accident and which includes overdose deaths, or natural causes such as, for example, cardiopulmonary conditions like cardiomyopathy or severe infections. The remainder of deaths shown were due to suicide, one homicide, and undetermined. So we'll now turn to the infant cases reviewed. These are 5 years of data on infant mortality cases. And again, infant mortality is defined as a death of a live-born infant in the first year of life. So looking at the graphs from 2013 to 2017, again, you see totals in the far right category. The raw data do show a slight negative trend there. But remember, as Dr. Cherry pointed out, our live birth rate is decreasing. So for instance, for calendar year 2015, there were 139 infant deaths reviewed, and the infant mortality rate for that year was 7.02 infant deaths per 1,000 live births. The following year, 2016, we had the exact same number of infant deaths, 139, but because of the live birth rate going down, the mortality rate increased to 7.28 deaths per 1,000 live births. And for comparison to national trends, the CDC reported US infant mortality rates for those years at 5.9 infant deaths per 1,000 live births. The manner of deaths, again, are broken down by year and dominated by those two categories of natural and undetermined. And so those are our 2 slides on the IMMRP statistics. And with that, I will open it up to questions for Mr. Izzo and me.
Do we have any questions of our presenters? Who had questions? Senator Woodrum.
Thank you, Mr. Chairman. I had a couple of things on the CFR case reviews. When you have a case review that say for an infant that's died possibly from some sort of suffocation, or that's been a contributing factor to the death, do you refer that back to a county prosecuting attorney after your review, or to law enforcement to see if there are other, I'm speaking of other factors that might be involved, some sort of intoxication or something that led to the incident?
Yes, sir. 100% of our cases that involve children have a direct referral process to Child Protective Services. And we also attempt, and we're in the high 90% of doing a reconstruction with the local law enforcement. And it's law enforcement's responsibility to contact the proper prosecutor in that particular case. But we do those referrals.
Thank you, sir. I have a few questions on the, we look at fetal drug overdoses by drug type. How do you got them broken out into different drugs, but if you have multiple drugs present, how do you deal with that?
With regard to overdose deaths, West Virginia is quite frankly ahead of the curve and has been for several years. We report every substance that has been found to be contributory on the death certificate. Those are of course coded out by the Health Statistics Center and eventually the CDC to break those out. When we provide the data, the Health Statistics Center does a very good job of breaking out the individual substances that were in a particular decedent's system at the time of death. But it's not within the scope of practice for forensic pathologists to determine that substance A contributed slightly more than substance B did, or substance C, et cetera. That's the main reason for having all of the substances listed, because the science is not there to determine which of those particular substance was more at fault than another substance would be, sir.
So if you have one individual with multiple drugs, all the drugs show up on this chart just in by category. Is how you're doing.
That is correct, sir.
All right. Now, the reports we're looking at, are there an annual report? Is that correct?
Yes, sir. They were supposed to be annual reports submitted.
And are the reports timely or is this report late?
They are late, sir.
How late are they? Was it due in December or of last year?
Yeah, some of the reports were submitted as individual reports and the proper process was not followed to consolidate those into a single report that's due to the governor's office and to LACRA. We have since pulled all of the legacy reports back to bring everything current by December 1st of 2022.
So we've got several years of reports not being.
That's correct. That's correct, sir. There has not been a consolidated report.
And are you trying to go back and bring those reports for past years together to submit those to?
We have all of the individual reports that were completed as legacy reports, and we are combining them as the statute requires us to into an overall report for each calendar year that covers different years of study with respect to the individual panels.
Okay, and the purpose of those was to study maternal and infant mortality and to try to identify the root causes. Is that the purpose of those reports?
It's for each one of the individual panels, sir. You have a child fatality, you have a domestic violence fatality, you have infant and maternal mortality review, and you have the unintentional pharmaceutical drug overdose review. So all four of those panels will complete individual reports to the FMRT. Those will be consolidated and pushed forward as in accordance with the statute.
Okay. Generally, what is the purpose for these reports? Is it to provide education or to reduce adverse outcomes? What?
Yes, sir. It's a multidisciplinary approach to take a look at these individual deaths to see if anything can be prevented, if there are any recommendations that come from the multidisciplinary panel members with regard to changes that could be made in services or code or anything that the individual panels come up with regard to recommendations to, for example, decrease the number of child fatalities in West Virginia as far as the child fatality report goes, domestic violence, et cetera.
Okay, so the delay in reporting the information and the consequences to mothers and infants in West Virginia, potentially information in this report could have saved some lives.
I believe that there could have been recommendations in the previous panels that they could have made a difference or in perhaps looking at prevention and treatment. Yes, sir.
All right, sir. I know we've been looking at this in LACRA and we're going to continue to focus on some of this to try to improve these outcomes. But we've had a number of opportunities, so apparently over several years now, that have been missed. But I thank you for your presentation.
Yes, sir.
Thank you, Mr. Chairman.
Delegate Tully.
Thank you again, Mr. Chairman. Thank you, Mr. Izay, for being here. I have a question. Is a case ever referred to more than one of the panels, or does it exclusively go to one panel? Because you could have a child that has a preventable death that's also an unintentional pharmaceutical overdose. Do you have two panels that review, or is it just referred to one panel?
It is possible for a single case to be reviewed by multiple panels. You'll see that a lot, especially in between the child death and the IMMRP is a good example of that as well.
Okay, and is there delineation anywhere in the process for, say, a child fatality that may have already had previous CPS involvement. How does the Office of the Chief Medical Examiner look at CPS involvement with cases that are referred to them, like that you end up with the child to do the autopsy? How do you check a system? Do you talk to anybody? How's the communication flow?
Yes, we utilize requests, and we consider CPS to be a law enforcement type of agency. So as we are doing triage and the forensic pathologist is assigned to the case, we will issue an administrative subpoena to CPS asking for any records with that particular child or that particular house, that particular family, depending upon the type of death and the triage that's been done in the case. The forensic pathologist has to take that information, the information gathered at the death scene, any information from law enforcement, and any other agencies that provide us with documents, and create the totality of the circumstances surrounding the picture of the cause and manner of that particular death. It's more important with regard to the manner, as the cause is generally able to be determined in a vast majority of cases. But like I was talking about, the ability to distinguish between two possibilities on the manner side is very dependent upon the reports that we receive from law enforcement, CPS, APS, et cetera.
And if your agency ever receives a child that is autopsied and dies under suspicious circumstances, and there was CPS involvement, but CPS maybe didn't make a catch, or there was a questionable finding, do you ever communicate that information to the OIG within the DHHR?
I am not aware of any cases that have been referred to the OIG, ma'am. I do know that we make reports on 100% of the child fatalities that we receive as cases at the OCME.
And your agency is under the same umbrella. It's under the DHHR umbrella, correct?
That's correct. We're in the Bureau for Public Health.
Okay. Thank you very much. I appreciate your time.
Yes, ma'am.
Delegate Pushkin.
That's a question for Dr. Didden.
Yes, sir.
Yeah, thank you for being here. And I appreciate the brevity. There's two slides on infant mortality rates here. The breakdown is just by cause. Is by cause. Is it possible to get from the Bureau for Public Health a breakdown, more detailed breakdowns by race?
Yes, sir. Absolutely. And we have a report that includes multiple additional factors: race, maternal education, prenatal care, and we can get that to the committee. I'm fairly certain.
Okay. Because while we're sitting here, I received a report from WVU from 2020. Opening first line of the report says that Black infants die at almost twice the rate of white infants in West Virginia. Now, from the statistics that Dr. Cherry presented earlier,
Right.
But 3.1% of the births are Black non-Hispanic infants, yet more than twice as likely to die.
Right.
In childbirth.
Yeah. Yeah.
So I think it's important for us to have that information if we're going to address why in the state with one of the highest mortality rates, there is a subset that has an even higher mortality rate. I think it'd be important for
Right.
us to get that information.
Absolutely. And appreciate that question, Delegate, because in addition to providing some data, I would really like to give an update on our efforts to address health equity. As you're all aware, there's no physiological explanation for that disparity. So we need to dig down into the details to help sort out why that disparity is occurring. We are not just waiting, though, for further analysis. We're working with communities that historically have reached out into the African-American community in West Virginia. based on experiences in the pandemic and working with the Dunbar School Foundation in Fairmont, we are hoping to get more information, qualitative data from the minority communities, and to be able to find out just what services are needed. One of the promising practices we're looking at is establishing through our home visiting program a doula network. So doulas are birth attendants, birth assistants, knowledgeable in prenatal care, knowledgeable in labor and delivery. They don't do deliveries, but it's another contact point that is evidence-based, and that we should be able to, without too much difficulty, at least step up and create a demonstration project in some of our hardest hit communities. And if it looks like that's a successful measure, be able to create a sustainable support mechanism for those projects. So we're not ignoring those data by any means. The strategy I'm taking is, if we can improve outcomes in the communities of West Virginia that are the hardest hit, we should be able to translate those promising practices across the state. So we're aware of the disparities, working with our academic partners who are also studying this and moving forward.
Thank you. Thank you, Mr. Chairman.
Senator Azinger.
If you've already mentioned this, I apologize. I'm curious, out of the overdose deaths, obviously those, I assume, are not all citizens of West Virginia. I know in Wood County, we get a disproportionate amount of, we have a disproportionate amount of beds, about 25% of the beds in the state, about 5% of the population. So do we know the citizenship of the overdose deaths, where these folks are from? Either, West Virginia or these other states being sent.
Yes, sir. That data is available. I did not bring it with me, but you are correct. This covers deaths that occur physically within the boundaries of West Virginia. And you'll see places like Wood County, places like Cabell County, probably up here in the Panhandle, that have larger communities on the other side of the border with primary care.
Or sometimes they're
facilities.
sent from other states,
Yes, sir.
they could be from Oklahoma or, wherever.
But the data set will include the state of residence.
Okay. Is there any way I could get that?
Yeah.
I'd love to see that.
Yes, sir.
Thank you very much. Thank you, Mr. Chairman.
Senator Jeffries.
Anyway, one of the problems we're having in our area is we can't get OBGYNs to move into our state because they have fear of what this body might do to have doctors who are performing abortions, for example, lose their medical license for doing that. I don't know if I'm not quite sure why people assume that that's exactly what's going to happen, but they can't even they've hired headhunters to get OBGYNs to come to our community. We're a desirable place to live. And we can't get anybody to even apply for those jobs. And I would think that would have a relationship with the healthy outcome of births.
A good point, Senator. We have struggled, I think, as a provider shortage area for years. And if we're able to activate our nurse midwives and successfully recruit more obstetricians to the state, I think partnering with local organizations that, like the Perinatal Partnership, and their agencies, their partner agencies in each region. I think we can send the message that we are in support of reproductive health for women, and that this is a promising place to come and practice medicine. But it's a tough sell, and it's not just in medicine. Obviously, we're having workforce issues across sectors, but you know, we're going to continue to try to establish best practices and standards of care. And I hope we'll be able to convince some more providers that that this is a good place to practice medicine. The distance to a birthing hospital is a major issue. So we're going to continue to work with the perinatal partnership to try to solve some of these problems and come up with some structural changes that I'm hopeful will activate more local resources, get nurses and other members of the care team practicing at the top of their license, so that rather than having to transport someone 2 hours to get an evaluation done, we may be able to provide those resources more closer to home.
Delegate Summers.
Thank you. My question is for Chief Izzo. You were speaking to Senator Woodrum about the last time you did the reports, and I wasn't following you. Are you telling me that you guys have done the individual reports, but you just didn't consolidate them to make one report as the code says, or did you not do the individual reports either?
We did the individual reports, ma'am. We did not consolidate them and submit them in accordance with the code.
Could you submit them to us though, just individually?
Yes, we could. And we did do that in some cases in years past, and they were published on the legislative side as individual reports. It's my understanding that we need to follow the code and consolidate all of those together. And we have all of them. They're in the final review process right now, and they will all be submitted prior to the December 1st, 2022 deadline to get them all caught up.
Right. I mean, if it's in the code, that's a law. It's not usually a suggestion. So you're absolutely right there.
Yes,
But what is the reason? What is the reason that we couldn't get it done?
I can speak to the time that I've been here, and it was a failure on my part to understand that they needed to be consolidated. It was a failure of some of the actual FMRT meetings to occur. There was quite a few shortcomings on our side that contributed to us not meeting the requirement, ma'am.
I think the biggest worry for us is, as lawmakers, is how do we make quick policy changes if there's an issue that's revealed in those reports? Is there something though, if you saw a trend happening, say with a certain product, right? We get product recalls, we get crib slats, right? That are made to be closer together because infants are getting their heads stuck in there and dying. Like if something like that was occurring, do you think though you would see a pattern and you would alert us? Or not?
Yes, ma'am. I think that the interdisciplinary design of the teams brings the right agencies and people to the review panels. We do have good communication, for example, with the Board of Pharmacy, with the law enforcement side through the state police, the county. We have some county and some local participants as well. So that type of communication is going on at the monthly meetings, but it has not been consolidated and pushed up the way that it should be.
Well, that makes me feel better that if there's something going on, you would be aware of that and you would let us know. On the child fatality, I saw 37% undetermined. So 1/3 of families are just never going to know why their child died.
The short answer to that, ma'am, is yes. There are competing, they're going to understand the cause of death. But there are competing manners to where it may have been an accident, it may have been natural. There's a blurred line between the two that the forensic pathologist doesn't have enough evidence or information to decide between the two. And rather than pin the rose on one or the other, the standard of practice is to make that undetermined, because there's a competition there that cannot be clarified.
Okay, yeah, I understand that then. Yes, so they know the cause, but they don't know the manner, so they mark it undetermined. Okay,
Yeah,
okay.
yes.
All
ma'am.
right. Okay, thank you very much.
Senator Woodrum had a follow-up question.
Thank you, Mr. Chairman. On these reports, I know we have a broad overview here, but when we get into like accidental deaths, is there more granular data?
Oh,
And- and-
yes, quite a bit more, multiple demographics across each one of the years studied, and each year is broken out separately, sir.
Okay, and does the state still issue morbidity and mortality report? You know,
I'm sorry, sir, I didn't hear.
does the state still issue a morbidity and mortality report?
If that's done, it's outside of my office, sir, and I'm not aware of it.
All right, thank you, sir. Thank you, Mr. Chairman.
Okay, I believe that
Delegate Reed, this will have to be the last question because we have one more presenter.
Thank you, Mr. Chairman. I actually have two drug questions. The first one has to do with your fatal overdose drug type trend. There's a cluster down at the bottom of Selexia, amitriptyline, and methadone, of all things. Is that indicative of people who are trying to get help? Is why those drugs are included in there, and then they just say had a bad at fentanyl, and it's showing up in the drug screen?
Yeah. Sir, with regard to that drug cluster, now that we have become better through the CSMP and some of the other tools that we have to look at prescription status, it's going to become more clear in that particular time frame. In those years back, the ability to study and break those out was severely limited.
Okay, my second question is on the next page. You broke out like the top 5, a bunch of fentanyls, morphines, and you broke out amphetamine. On the previous one, you just had methamphetamine going way up, and then you broke it out to methamphetamine and amphetamine. Is that the prescription Adderall?
Did you say Adderall, sir?
Yeah, is that the prescription?
I'm sorry,
amphetamine?
sir. I'm not a chemist, or I'm not the right person to answer that question.
All right, thank you so much.
Okay, and we appreciate your attendance today. And now I'd like to call our last presenter to the podium, Dr. Jonathan Hartens. Dr. Hartens, as is the custom of this committee, we will swear you in. Do you swear or affirm that the testimony that you're about to give is the truth, the whole truth, and nothing but the truth? So help you God?
I do.
Then the podium is yours. Please state your name and position for the record, and we look forward to your presentation.
My name is Jonathan Hartens. I'm a clinical psychologist and the CEO of Mountaineer Behavioral Health, and also speaking today as a board member of Semper Libre Incorporated. Thank you, Mr. Chairman and members of the committee. I realize it's been a long day, and being the last one, I know many of you have your minds already directed elsewhere. So I will try to be brief and give you some information about what we're doing in the state's efforts to combat the opioid epidemic and the substance abuse problem within the state, and also give you some tangible needs that we have as one of many providers within the state that I think other providers share with us, as well. Hopefully, everybody has with you a packet that is bound together with a spiral bound. And I want to just walk you through that about who we are and what we do and what the issues are that we face. On the inside is first page is our mission for Mountaineer Behavioral Health. And the next page is the vision. And I want to emphasize that a certain element of that vision, which is to be a provider of choice. And about 95% of our clients are Medicaid-based patients. They do not have a choice, many of them, on where they get to go for substance abuse treatment. Many of them are court-ordered. Many of them come because we're the only thing in the geographic area of the Eastern Panhandle that provides these services. And despite that, our goal is to be a provider of choice, meaning that if you had plenty of money to go anywhere, that you would choose to come to Mountaineer Recovery Center. And our goal is to provide our patients there with the dignity, respect, and the care that they get, and in the facilities that they're residing in, to be able to really begin to believe that hope and change is possible. Turning to the next page in your booklet, who we serve in 2021, Mountaineer Recovery Center we admitted over 500 patients each year in 20 and 21, despite COVID. We didn't close down any operations. We continued operating full steam ahead in the midst of all of the COVID restrictions. Many of you are familiar with medication assistance treatment services, and we provide 20 MAT groups on an outpatient basis, and we serve patients in Berkeley, Jefferson, and here in Morgan counties. One of the things that's been most surprising to me has been the diversity of the clientele that we serve. When we first opened in the end of 2019, our expectation was we would be serving the residents of the Eastern Panhandle. We track where all of our residents come from, and over 20% come from outside of the Eastern Panhandle. And we've gotten referrals from all 55 counties, Mingo County, Mercer County, Cabell County. And one of the things that I will ask our patients when they come to us, why did you go past so many other substance abuse treatment facilities to come to Mountaineer? And many of them say that they come from other areas because they want to get a fresh start in a new environment. And then plus the Eastern Panhandle has many opportunities for work and employment, and that I'll speak to here in a few minutes. But that gives them a fresh start to not only get clean, but to start their life over. On the next page, we kind of go over what we do in providing a full array of substance abuse services, outpatient services, residential treatment, and then also the array of services through individual, family, and group counseling. Early this year, we opened up the Mountaineer Women's Center, and it was an addition to our residential facilities. And what that enabled us to do was to increase the number of beds available for women, and particularly enable women to come into treatment with their children. And so we find that so often women in particular would have to choose between keeping their children or going into treatment, but they couldn't do both. And this allowed them the opportunity to do that. There's been challenges as we've been trying to meet the needs of West Virginia residents with providing them substance abuse services. And one of the things I wanted to bring to your attention and come to you for support and help is the needed funding and regulatory support for survival. And as has already been spoken to about the lack of OBGYN providers, we also have a gross undersupply of psychiatric providers, psychiatric nurse practitioners, MD psychiatrists, and PAs who also have psychiatric training. Just a few statistics there are there in your booklet. West Virginia, relative to The nation has a great undersupply of psychiatric providers. The statistic that I put there in your booklet shows that nationwide, 1 out of every 4 American citizens has access to a psychiatric provider. That's still not very good. That means 3 out of 4 people who need psychiatric care do not have it, but 1 out of 4 do. And in West Virginia, that statistic is much lower, with only 12% of those who need psychiatric care have access to that. That creates a big problem for us in that DHHR has come to us because we've been very agile as an organization and very willing to serve the state and the community. We've been asked to take on more services and provide more resources to the community. And we're very much hindered because we cannot get an adequate supply of providers to help us with fulfilling those needs. On the next page is another element of the overall comprehensive care, and that's just the lack of behavioral health providers, social workers, master's level counselors, licensed professional counselors, psychologists. And it's very interesting to me to look at our surrounding states and look at what the ratio is of master's level or above behavioral health providers relative to the population. And you see our border states listed there. Maryland has the best ratio of 1 to 390. And then it gradually, incrementally moves up with Ohio, Kentucky, and Virginia. And then towards the bottom is West Virginia with a ratio of 1 counselor for 770 residents. And statewide, that ranks as 48. So there's only 2 other states with a lower ratio of providers. For myself, being in the trenches, the biggest reason that I have for not being able to recruit effectively is pay. It becomes a money issue. And one of the challenges that we have as a residential treatment provider is we get paid on a per diem basis. So every patient that comes in and stays at Mountaineer or any other substance abuse facility within the state, some of them may be within your areas of oversight or representation. Those facilities are required to have psychiatric service, a medical service, nursing service, case management service, and social work service. If you go down just a few miles here from the state resort and go into Winchester, a facility that would be comparable to ours would get a reimbursement rate of $423 per day per patient. If we were all West Virginia private insurance like PEIA or Highmark Blue Cross Blue Shield, we could get a minimum of $500 to $600 per patient. And in fact, there are multiple private facilities that come into West Virginia to recruit and acquire private paying patients or those with private insurance to go to places like Florida, to go to places like Pennsylvania, other states around the country, because private insurance will pay at a reasonable rate to be able to make ends meet.
Dr. Harding, I do
rate-
need to let you
Yes,
know,
sir.
we've got about 5 minutes. Do we have another group right behind us? So about 5 minutes, if you could, and
Thank
we
you,
won't
Mr.
have any
Chairman.
questions, but he will be available, I'm sure, for questions afterwards.
Thank you, Mr. Chairman. So our West Virginia Medicaid rate is $225, less than half of what the private insurance rate is. And so the Medicaid funding rate is a challenge for us to operate on and creates problems for us to be able to recruit effectively for staffing. I want to change hats for a minute and move to Mountaineer Behavioral Health will provide services for medical reimbursement services that Medicaid can pay for. But many of our patients who leave and graduate from treatment need follow-on social services that Medicaid will not reimburse for. And those kinds of things are where Semper Libre, a nonprofit in the community of which I'm a board member, tries to pick up and provide those services specifically to those who are leaving treatment and trying to reintegrate back into the community. A couple highlights from what Semper Libri has done in the last few years. If you turn a few pages, we opened up the Ashley House. It's the only certified recovery residence in Morgan, Jefferson, and Berkeley County that's certified by the West Virginia Association of Recovery Residences. It's a home that provides recovery support for 6 women in early recovery after they leave treatment. Semper Libri opened that in 2020. At the same time, the governor launched the 2020 Substance Use Response Plan. And on the page that follows is a model of care which shows a collaboration of multiple providers. And regretfully, that model of collaboration has not come to pass within the state. Most agencies are still operating under a silo. And so what Semper Libri has done with the success of the Ashley House is looked at creating a 200 housing unit recovery residence neighborhood that would be exclusively for those who are in early recovery. The property's already been purchased. We're already in the first phase of development of that project. And there's a schemata with the overall model that provides housing for affordable housing for up to 200 members and their families. There's a page there that lists the different phases of the project: 4.5 million, 11.2, 6.5, 2.4, and 3.2. We are in phase 1, and a couple of weeks ago, Senator Capito came out for the groundbreaking, and we had that ceremony. And we are looking to create a model that's collaborative with providing workforce development to get the people who have finished rehab back into the workforce. And we partner with James Rumsey Technical School, Blue Ridge Community College, our Chamber of Commerce, and Workforce West Virginia to get members back into the workforce. With education providers, as those I've mentioned, and also our healthcare providers. Towards the end, Mr. Chairman, is a picture with the village summary, and appreciate your time looking over that. And just to emphasize, our main takeaway points is needing help to be able to have the funds to recruit psychiatric providers, behavioral health providers, and also to be able to finish the Mountaineer Recovery Village.
Okay.
Thank you for having me, Mr. Chairman.
And thank you. And I'm sure you'll make yourself available for questioning afterwards. At this time, the chair looks to the co-chair for the purpose of a motion.
I move we adjourn.
The co-chairman moves that we adjourn. All those in favor, please signify by saying aye. Those opposed, no. The ayes have it. I declare that we're adjourned.